Dr. Sanchez-Riley asked me to talk a little bit about some advanced topics of bereavement. We had a session this morning with Carla about the basics of bereavement. And if my computer starts working all right, we'll get through a couple of more advanced topics, and then Carla and I also want to present to you our model of the bereavement group that we've been running this year, and it's still in its developmental phase, so some of our materials aren't yet put together, but we wanted to share what we do have with you. Before we get started, all of you mind introducing yourself again so I know who's who and what discipline you're coming from as well?
Carla Sims, Central Texas, VA, social work service, and I'm a Hospice Care for position part of the Central Texas Hospice Consulting.
Elizabeth Polanco, physician, Dallas, VA, Palliative Hospice.
Robin Sullins, I'm staff chaplain at Dallas VA, and one of my areas is the hospice.
One of the many, I'm sure.
Still includes nurse manager, hospice and palliative.
And we've got a couple others in the back joining us.
Yeah, I'm Dr. Denise Minorant. I'm a nurse with the Palliative Care team.
I'm Dr. Reimer, I'm a psychologist with the Palliative Care and nursing home care units here.
Carla, yeah, social work fellow with Geri-Care.
Okay, the computer looks like it's thinking, which is hopefully a good sign. There we go. All right. So the objectives for this session are threefold. To describe complicated grief and differentiate it from major depressive disorder and post-traumatic stress disorder. The second objective is to describe the dual process model of coping with bereavement and its implications for practice. And thirdly, to describe the elements of our 10-week group bereavement intervention. Hopefully the didactic portion will take only about 30 minutes or so, and I really want to get some discussion going when we present the group intervention and possibly get into some case examples depending on how our timing goes. And if questions arise during the course of the presentation, please feel free to ask as we go along. In terms of complicated grief, I just want to open it up. I saw somebody with, is that your Brando book of complicated grief? Yeah. What do you know about complicated grief and what it is and how it's different from common grief?
Lasts, and lasts.
So it's chronic grief. Okay. Anything else?
Well, they talked earlier about the risk factors for complicated grief. There's certain individuals that are at greater risk for complicated grief and the characteristics of that.
Okay, great. So yeah, there are certain characteristics of the individual, certain characteristics of the type of loss that may leave an individual prone to complications of grief. What else?
Basically interferes with normal life function.
Yeah, it's impairing. In some way, the individual has difficulty with carrying out their daily activities, getting through work, continuing to engage in their social relationships, those kinds of the basic tasks of life. There's a lot about this time of year. Well, let me tell you a little bit about what the literature says about patterns of grief. Not only colleague conducted a study published in 2002 where they identified 5 different patterns of grief. We're going to go through all 5 of them. Let me tell you a little bit about the study first. There were 205 participants in the study. They all had all experienced spousal loss. They were mostly older. The mean age was about 70 years old. The Nano and colleagues measured depressive symptoms prior and grief symptoms prior to the loss, at 6 months after the loss and at 18 months after the loss. The 5 patterns they identified accounted for 90% of the individuals, or it was about 185 of their subjects. The remaining roughly 10% of individuals in this study demonstrated patterns that the authors described as delayed grief, so those grief symptoms didn't increase until later on in the study interval. Delayed improved, so there was a delay in the grief symptoms and then improvement further on, or an improved relapsed pattern. So what the author said, that this sort of indicates that common belief or idea in the literature that delayed reactions are impairing and pretty common didn't seem to hold up in this study. Most individuals, as you see on the slide, fell in this resilience category. They had their pre- and post-loss depression and grief symptoms were rather low in comparison to the other individuals. So these folks seem to have gone through pre- and post-loss experiences rather well. So we probably won't see these folks too much in our practice. Common grief represented about 10% of the individuals in this study. And these folks showed short-term grief distress after the loss with minimal depressive symptoms. So by 18 months, their grief symptoms were back to a fairly low level, similar to the resilient group, not causing too much distress. A third group was identified as improved depression group. This was another about roughly 10% of the individuals. These folks had pre-loss depression that was significant and that improved after the loss. They also showed decreased grief symptoms over time. One of the interesting things of note about this group of subjects was that they tended to report the poorest quality of relationship with their spouse compared with folks in the other groups. So these are the people who might have experienced a sense of relief at the loss. There also in this group were folks whose spouse was likely to be ill prior to the loss. So again, consistent with that idea that caregiving and the stress of that, poor quality relationship after a loss, there's a sense of relief that can go along with that loss. Again, those improved depressed folks, we might see them for a little while in our practice, but for the most part, they're gonna move through the grief process rather naturally and without significant difficulty. The last two groups are the folks that we're going to be most likely to encounter in our practice, who are going to have the most difficulty. And they represent about 25% of this sample. One of those groups is the chronic grief group. This was about 16% of folks who showed prolonged grief distress. So their grief reactions remained relatively high throughout the 18 months of the study. And their depressive symptoms also remained rather moderate. And then the chronic depression group, which represented about 8% in this sample, had pre-loss depression symptoms that continued after the loss and relatively high grief symptoms as well throughout the study period. There were a few particular predictors of these two groups, the chronic grief group and the chronic depression group. Both of these groups reported higher dependency on their spouse and higher just interpersonal dependency in general. So these folks tend to be more dependent on others. Think about grief as a reaction of losing an attachment, it makes sense that someone who's rather dependent would have more difficulty with the loss of a significant attachment. These folks in both the chronic grief and chronic depression group also reported less instrumental support from other people. So they perceived that they were less likely than folks in the other three groups to receive direct assistance from family or friends with their housework or with maintenance activities around their homes, with financial assistance in case they needed that, or if they became ill, they believed they were less likely to receive support. So assessing for social support is going to be important when you're working with folks prior to the loss and after the loss, of course. The individuals in the chronic grief group were more likely to have had a healthy spouse prior to the death. So the losses were surprising in some way, sudden, so the grief was more difficult to resolve. The chronic depressed group were more likely to have lower perceived coping abilities. And these are folks who were moderately depressed before the loss, so poor coping skills goes along with depression anyways. It seemed to make a lot of sense. They're also more likely to be neurotic and introverted, and to perceive events as uncontrollable. So the people with chronic depression type of grief, bless you, are more likely to just have these long-term enduring problems with emotion regulation and coping. Of course, one of the limitations with this, taking this data and applying it elsewhere, is that the individuals in the study experienced only spousal loss. They were older, so we're not sure how it applies to individuals who are younger or other types of loss. This kind of gives you a sense of some prevalence rates. About 25% of individuals, and that's supported with some other studies, have some kind of a complicated course of their grief. There have been efforts as well to develop diagnostic criteria for complicated grief as its own diagnostic category in the DSM. And I've just briefly listed the general criterion. If you want more specifics, I'm happy to provide that information for you. But just want to note a couple of things on here. One is the proposed diagnostic criteria for complicated grief involves both separation distress and what they're calling traumatic distress. And the separation distress criteria includes symptoms like having intrusive thoughts about the deceased, yearning or searching for the deceased, and excessive loneliness. You might think of them as almost like the PTSD re-experiencing symptoms. They have some similarities with that, which is when it gets kind of challenging to distinguish the two. The traumatic distress tends to be more like an avoidance symptom. The individual, and among the symptoms in this category are purposelessness, feelings of futility about the future, numbness, disbelief, feeling that life is empty, shattered worldview, excessive irritability, bitterness, or anger related to the death. And the duration, the consensus among the committee that developed these criteria was that the duration of these symptoms needed to be at least 6 months, and that from the start of the symptoms, not necessarily at the time of the death. at least 6 months, and of course, they needed to be clinically significant. So they're interfering with the social, occupational, or other roles the individual has. One of the criticisms of these criteria is that it's hard to really distinguish the criteria from major depressive disorder and PTSD, and I'm going to do my best based on what I've read in the literature to make that distinction. It's still pretty fine in my mind, so bear with me here. To distinguish, I've set up the different criteria next to one another in some ways so we can make some comparisons. With post-traumatic stress disorder, the trigger is some kind of physical threat or perceived physical threat to oneself or another. Whereas complicated grief is triggered by a loss. And that loss very well could have involved something traumatic and something threatening, but what is most disruptive is the loss itself, not necessarily the threat to oneself or to the other. The primary emotion involved with PTSD is fear and anxiety, whereas with complicated grief, the primary emotion you're going to pick up on is sadness, not so much the fear or anxiety. Nightmares are rather rare with complicated grief, whereas they're more common with PTSD. And in complicated grief, the reminders of the painful loss tend to be pervasive and unexpected, coming out of the blue, not necessarily linked with anything in particular that's associated with a specific event, which is how that is distinguished from PTSD. The reminders are linked to a specific event. They may be unexpected, those intrusive thoughts, but they're going to be specific to whatever the trauma was. And with complicated grief, that may involve yearning or longing for the deceased, whereas with PTSD, most of the veterans I've talked with have no longing or yearning at all for the trauma. And the events and thoughts in complicated grief may also be more pleasant than what you encounter in someone describing more of a PTSD kind of reaction. To kind of differentiate complicated grief from major depressive disorder, again, you've got that feeling of sadness, but the sadness in grief is related primarily to missing the deceased individual, whereas with major depressive disorder, it's a very pervasive sadness, or just the wet blanket kind of feel. The loss of interest that you see in major depressive disorder may not extend as greatly in complicated grief, where you still see the individual very interested in memories or events or activities that are associated with their lost loved one. The guilt is more focused in complicated grief, focusing on the interactions they've had with their loved one. The rumination that you see in major depressive disorder is more inwardly directed or self-directed about past failures or misdeeds, whereas the rumination you see with complicated grief is more about the other person and the memories associated with the other person. The other thing to keep in mind is that studies have indicated that grief is not as responsive to antidepressants as major depressive disorder. So that, and even certain therapies may not be as effective with grief as others. So in one study, they found that interpersonal psychotherapy was not as effective at treating the complicated grief, and nor were antidepressant medications. The literature in the research on these criteria of complicated grief indicates that individuals who report more of these symptoms report poor mental and physical health. and that it may be these complicated grief reactions that mediates the relationship between losing a loved one and morbidity and mortality. So the literature has, over the years, has shown that there's a relationship between losing someone to death and poorer health or risk of death. But studies indicate that it's the complicated reaction that makes that connection more so than just bereavement on its own. So participants who met these preliminary criteria were more likely to have had comorbid major depressive disorder and high blood pressure. It's not just bereavement on its own that seems to have this effect. It's these complicated reactions. And among a sample of bereft spouses, about 1/4 met criteria for complicated grief at 3 points in the study. I believe it was 3 months after the loss, 6 months, and 18 months. These individuals reported more life stressors and less perceived social support than did participants without complicated grief. And this just again reinforces what you all were saying earlier, that the risk factors included poorer social support and more stresses. And factor analytic studies are providing some initial evidence that this complicated grief is independent from major depressive disorder or PTSD. So down the road, we may be seeing this in the DSM as its own diagnostic category.
Other than being VCO.
Right. Yeah. You would still have bereavement as a V code, but then you would have complicated bereavement, complicated grief as an additional diagnostic criterion or category. Yeah. Treatment recommendations, and this is consistent with Rando's work and that of Holly Frigerson and her colleagues, who's really taken the lead in developing these criteria, is to address both prongs, the separation distress and the trauma distress, through different treatments. You address the trauma through exposure therapy or other treatments specific to trauma, and then you address the loss or the separation distress with grief therapies or cognitive behavioral therapy. And Kathleen Shear, she's at the University of Pittsburgh, I believe, she conducted one pilot study, and they've had one randomized controlled trial examining the combination of interpersonal psychotherapy with CBT to treat these complicated grief reactions. And the interpersonal therapy was used to address the grief-related depression, and the cognitive behavioral therapy was used to address the trauma-related distress. And their studies thus far have provided some support for the effectiveness of this sort of two-pronged treatment approach. So to summarize what I've talked about with complicated grief, most individuals, as we saw with the patterns of grief, navigate the grief process rather well on their own. They may need some education about what may be common or what's to be expected. About 1/4 of individuals will show a more complicated grief reaction indicated by prolonged and clinically significant depressive, grief, or PTSD-like symptoms. Again, you all told me this before I started. You're all so smart. And complicated grief involves separation distress and traumatic distress reactions to the loss. Research on the proposed diagnostic criteria suggests that it is independent from major depressive disorder and PTSD. Although further research on that is definitely needed. And treatments that address both the separation distress and the traumatic distress show some initial evidence for its effectiveness. Any questions or comments on this portion? I want you to keep in mind that two-pronged treatment, because the next topic is the dual process model of coping with bereavement. Anyone familiar with this model? It's this model is based on the work of Margaret Strobe and her colleagues in the Netherlands. They developed the model in response to some criticisms they have of the grief work hypothesis. And they describe the grief work hypothesis in this way: that one has to confront the experience of bereavement in order to come to terms with the loss and avoid detrimental health consequences. And Strobe and colleagues noted that, well, that's not always the case, that confronting the loss is going to be helpful or effective. It's a very Western idea, so there's some cultural and gender limitations to that idea of this grief work hypothesis. Additionally, they noted that people need a break from confronting grief and doing the work of grief. They need to take a rest from that. And the existing models of coping with bereavement didn't take that into account. So they reviewed the literature on theories of bereavement coping and the cognitive model of coping with stress and developed this dual process model of coping with bereavement. And the model postulates that coping with grief involves a very dynamic process of oscillation between confrontation with and avoidance of stressors associated with the loss. So there are two kinds of cognitive processes that are important for very adaptive functioning, adaptive coping with grief. You want to both confront it, and at times you want to avoid it. And that's going to facilitate coping. This is very different from traditional views of coping and traditional views of grief, which promote confrontation above avoidance. And additionally, coping with grief does not occupy all of an individual's time. They need to take time off from it, and people do that anyways. I think normalizing that and letting people know, hey, it's okay to enjoy yourself or to not think about your loved one for a while can be helpful in facilitating the grief process. With those expectations of what others think you ought to do that can interfere with adaptive coping. The model also identifies two different styles of coping: loss-oriented coping and restoration-oriented coping. Loss-oriented coping addresses things like the intrusion of the grief emotions, relocating the deceased in one's life, sort of that's the kind of traditional idea of grief work. It's part of that loss-oriented coping. When this kind of coping is overused, it leads to rumination, which can just spiral down to a deep, dark hole. The other style of coping, this restoration-oriented coping, addresses some of the secondary stressors that come along with grief. Having to learn to pay the bills and manage one's finances. How do I mow the lawn after my husband has died and I've never used a lawnmower? So adapting and attending to those different daily tasks and changes, learning new roles, creating a new identity, doing the things that are needed to reestablish a sense of normal, reestablish a sense of who one is without that individual. When this type of coping is overused, that can lead to denial of the loss or suppression of one's emotions. The interesting thing about this is thinking about it in terms of gender roles with regard to grief experiences. The loss-oriented coping is very similar to the traditional feminine role, feminine style of coping with grief, whereas the restoration-oriented coping is very similar to the more masculine style of coping with grief. So you can then see how in families, this model helps show how in families you can get the conflict where one individual, after the loss of a child, for instance, one individual is engaged in all the restoration-oriented coping, the other one's engaged in all the loss-oriented coping, and then get some conflict there. Here's a pictorial representation of the model. And the large oval representing everyday life experiences, that's the one I think that's important to pay attention to and how it's related to the other two ovals. Just reinforcing that the grief work, the loss-oriented and restoration-oriented coping, are not all of one's life experience. They're a portion of it and pretty significant, but it's not everything that the person is doing. And the lines back and forth between the two indicate that oscillation, moving from one style of coping to the other. And sometimes it's not a straight back and forth, but as you see, it moves, in this example, it moves from restoration-oriented coping to loss-oriented coping, through the everyday life experiences, back to restoration-oriented, and then out into everyday life experiences where you're not focusing on the grief, back to restoration-oriented coping, and so on and so forth. So the individual is moving backward and forward between these two styles of coping, and also, incorporating other life experiences. I find this a very helpful model. It seems to fit more with my personal experiences of grief. It fits more than a lot of than Worden or Rando's models with what I hear patients telling me as well. And the implications for this model focus on what happens when something fails, when there's a failure in this oscillation back and forth, and coping is either only loss-oriented, only restoration-oriented, or there's too much confrontation or too much avoidance. With overly confronting the loss orientation coping can lead to that rumination, which increases the risk for depression and more chronic grief. If there's too much avoidance of the loss-oriented coping, that can lead to a suppression of those negative emotions. You're just either not, or denial. You're not feeling them, you're not dealing with them, which adds stress and can eventually lead to illness. If the individual and their style of addressing the restoration-oriented coping, if they're overly confronting with that style, using that one too much, they may experience an inability to integrate the loss into their life. They're focused solely on moving on, getting on with things, which again can lead to depression or chronic grief. There may be denial of the loss and suppression of the negative emotions if they don't use that style. Wait, no, the first one is if they don't use the style, the second one is if they overuse it. Sorry about that. So in practice, the model can be helpful for thinking about assessing the grief coping style. Are they primarily using a loss-oriented style or a restoration-oriented style? Where might they need to sort of get a boost? You'll want to assess the confrontation avoidance dynamic. Are they over or underusing one of these cognitive styles? And then you want to assess their other self-care activities. What else are they doing that's promoting and taking a time out from their grief and getting a rest from that? Again, I find this a very helpful model. Hopefully you find some relevance with it as well. And this has been very influential in my thinking in preparing the grief intervention that Carla and I have developed. Thinking about, wanting to allow group members to spend some time thinking about the loss, thinking about ways that they are having to restructure their life, thinking about taking a break from it and providing self-care, and sort of moving back and forth the ebb and flow of grief. So I want to shift gears again. It's kind of a potpourri of grief topics, and talk with you about the group intervention that we developed. I don't know if you were provided with a big handout. Again, we're still in progress, so if you want to, if you're interested in receiving our updated final version after we run through the group, I'll be happy to take down your email addresses and send that to you when we wrap up. And if you all are doing grief groups, I'd really love to hear what you're doing as well. I just want to highlight a few things in the materials, and then we wanted to go through an exercise with you that hopefully will help integrate a lot of what you've been learning about today. So just want to draw your attention first to the third page, which talks about the objectives of the group and the assumptions that I think we have for the group. And our objectives are really to provide support for these individuals who are grieving the loss of a loved one. That's primary. We want to increase their awareness of and knowledge about their particular grief responses and coping practices, knowing that grief is such a unique experience. We want to create a space wherein participants may express and process their grief-related emotions and experiences, and promote their application of this new knowledge and skills to facilitate healing. We want them to be able to take this knowledge and move it beyond just the hour a week that we need.
Yeah. You're using this with families or with patients?
Patients.
Your hospice and palliative care?
We're using it with people who have lost a family. So we're using it with people who've had a loved one die.
So
It's not with the patient who is actually out.
Okay. I just want to be clear. And this, yeah, it's post-loss bereavement. Any kind of loss. We've primarily had folks who have lost spouses, parents, siblings.
And no children. Just we have had children.
The other child, yeah.
I think we tried for child reason. Luckily that hasn't come out.
Yeah.
Until just this moment.
Right. Generally, our group members have uncomplicated grief, and we've endeavored to screen out patients with severe cognitive impairment or active psychosis. I also wanted to draw your attention to page 6, which shows our schedule that we have and the different topics that we covering. So we've had 3 sessions thus far in this incarnation of the group. So the first group we talked about expectations for the group to help normalize the group process and the grief process and allow members to introduce one another and start establishing a sense of cohesion in the group. The second group, we talked about just the experience of loss and ways that family, culture, and social practices have influenced how they experience loss. And we're going to go through that, some of the activities we did that session today.
Is there an ideal number of people for this group?
Well, for groups in general, the ideal is around 8 to 10.
8 to 10.
We've been lucky to have 5 folks this time. And I know that there had been a grief group with a palliative care psychology fellow who run the last 2 years. And membership is pretty hard to come by.
It's our
4
experience as
folks
well.
is, you're lucky, yeah.
Thinking this is a wonderful service. No one shows up
Yeah,
for the classes.
yeah.
We usually have several confirmed, and then usually lose 2. Yeah. This last one, we had 2 women who lost children. And neither one, and they both confirmed. Yeah, people really
Sounded excited to come.
so. It's just avoidance. This time we have people that have more recent losses too, which is real admirable. Admirable getting in here so quickly.
Yeah,
What's considered an ideal number to...
we would love to have a couple of more, but we meet for an hour and a half, and we found with 5 folks, everyone had enough time to really introduce themselves and tell their story and not feel like you're stepping on anyone's toes. So that number, I think, has worked well for us in the way that we've approached things, and very supportive and process-oriented. In this last session, they all brought in photographs to share. And so with fewer numbers of people, you've got more time to really be able to share that information. And if I think we had 8 or 10, we would have had to cover that in probably 2 sessions.
Yeah, or for that, you could split it in part of the group. You do part of the group, you do part of the group, and come back.
Yeah.
You have a larger group. The one good thing of having 8 to 10 is attrition rate. If somebody's absent, you're going to average about 6 folks.
Yeah.
But good luck maintaining that.
Yeah, that's what, and that's interesting because it's such a dual role.
Yeah.
You're always hustling to get membership, like we're both sort of realizing, you're it's just a different role than you're used to in social work or psychology. It's like more business role, like it reminded me of,
Marketing.
yeah,
Yeah.
go to the death clerk and sending out letters, and you don't want to be cold calling people. Like, I noticed that your mom died. Just wanted, so there were a lot of logistical things around that. Just, how to send the letter out, and then, when you call, what kind of message can we use?
And what time seems to work the best for people?
That's another.
And really the challenge with the time is about parking more than anything else. When is the best time to get here to get a spot and get parked? Yeah.
Sarah, is there anything in the literature about the percentage I'm not sure if that's the right word, of people who would be interested in the group type support versus individual or just doing it on your own? Because I know there are people who don't do groups.
Right,
You know,
right.
so
And-
what
and with-
percentage of the population are group people?
And I don't know that in general. I don't know, Anne Marie, if you know that at all.
I agree that it's probably there.
Yeah.
So I think there's a large percentage of people who won't do their grieving at all.
Yeah.
And it may be different populations. We talked about earlier, if you've lost a child, you know, a lot of times people need the support of others who have lost a child also, as opposed to someone who's going through a different type of loss.
Yeah.
Yeah. Well, and I think just in general with bereavement, the support group, to me, is such a great tool because, you know, really it's the other members that are really going to help a person with their grief. At least that's been my experience thus far. I mean, I feel like I get a lot from just sitting listening to them with my own grief, you know, in my own life.
What kind of ages are you looking
Mid-40s to 70s, 80s.
at? And what time of day?
They meet in the mornings.
That is a problem for me, because I can remember hospice sending out letters for like a month, for a year, about groups and meetings, and their meetings were in the evening, and whereas a young person, 40, 50 years old, is still working, they don't have time to come to a meeting in the morning time. Like me, I didn't have time to go in the evening, so I'm like, I don't know, the timing is a factor too. If you still have jobs and you have children, you have time to come to a morning. And
Well,
working.
It would be
Parking.
It would be ideal to have both.
Sure.
We've even talked about it would be great to have an evening one, but we, as fellows, have to have it
License.
during the.
Yeah.
So, but yeah, having an evening option is, or even a weekend.
Or even a weekend.
Yes.
Would be ideal.
And perhaps even having it outside of the hospital. We had one individual referred to the group whose husband had died in the hospital and just could not face coming to the facility again. So one of the things we have been able to do is provide references to some of the community support groups and grief resources in the community for individuals who just don't feel like this would be a good fit for whatever reason, maybe time, maybe just not able to come here.
And these are veterans or veterans' families?
Yes.
Okay.
And it's interesting too, because right now we have several Vietnam veterans, and I think it really triggers, you know, some grief reaction to just, you know, surviving, you know, with other people who didn't survive. So, but once again, having several in a group, they bond with each other, and they're completely, you know, personality-wise, just from totally different walks of life, other than the fact that they are all vets. So that's really great to see too, you know, that they have that sort of commonality. And just the commonality of all being veterans too. So, or attached to the military in some ways. So there's a lot of features to that, which that's it's like when they shared photos, you know, it's also where they were buried, and so many of them were buried, you know, in the military cemetery, and then the memento of the flag, and all that, they get to share all that with each other. Sometimes it's just, I think we both have experienced allowing them to talk and us to be more silent.
Yeah, I think our role is really, we wanted to balance some education to normalize the experience and provide them with resources to help them move along their journey of grief, but also recognize that just the processing and the talking with sharing with one another is so healing that we need to get out of the way at times too. One of the other things we noticed that came up the first time we ran the group, the first time it was 5 weeks. We found that was way too short. But one thing that seemed to come up rather regularly was this idea of secondary losses, the regrets, either the past regrets or the future related regrets and those lost dreams that someone might have, and feelings of guilt. So we wanted to make sure that this time we incorporated that into its own session to really be able to focus on those experiences, to be able to process them, and then also to incorporate the idea of forgiveness and how that might fit in. And that's really one where I'm hoping we might be able to get the chaplain's input to help facilitate forgiveness. And then as we move along through the weeks, the last few sessions really are starting to turn the attention less from the group itself back to what's going to happen when you leave the group and starting to process the termination. Because here we are in a group, we've hopefully attached to one another in the group, and we're going to have to say goodbye all over again. What's that going to be like, and how can we help ourselves be prepared for that and know that we can take what we learn in the group and move on. And even encouraging folks to exchange contact information to continue those bonds outside of the group. So that's our thoughts and how we structured this, and we'll let you know how it turns out if you're interested.
My experience is that we just have a ready market. We have a 19-bed inpatient unit, and we just knew we were going to be flooded with people who were interested in doing grief work. And it's just amazing how there's little to no attendance. And I'm wondering if it's something that we're doing wrong, not marketing it right, the time is wrong. Because I kind of feel the way you all feel. I think this is very important for people who like group work. And I've always been amazed how we started up and we're all excited, and then I'm gonna grieve.
I think one thing we ran into, like in the past, was our catchment area is so large. Folks have to come a long way to come to the hospital for a group for 1 hour. And then drive 2 hours back home. And for a lot of them, it just was too much. Too much time. 4 hours for a 1 hour group.
It's a lot of investment.
But what you're thinking is for the inpatients in both of the transitional care units, to offer, y'all have offered it, and
Many
there's
times.
been
Little to no interest.
Because I don't know where your families come from, because even for our inpatient unit, we still have a lot of patients that are far away and their family live in Mahia. I mean, we get a few patients that are actually Houston area. And for whatever area, for whatever reason, they don't like going to the Houston VA. It's so big and the traffic is so much, and it's easy for them to take those little country roads and come on to Temple. And so when they end up becoming terminal, and they're getting care there, and they're sent them to our unit, and they are miles and miles from home and from folks that are close by. So that's been a real big issue at our facility, because folks love living in the country, and they're coming from a good little distance. Even to just visit, they're keeping in touch by phone. Either that or the spouses are pretty much moving in the rooms with them.
So have you had any one-time meetings or sessions?
No, we haven't done anything
that might be
recent.
another option.
That was something we had ran into in the past, and we just, with time constraints and other issues, we just hadn't gone back to the table to try to perfect that or work that out, to be honest. So that's something we still need to to work on and get through. But I know that was one of the big problems in the past. It was,
They're my nieces, they are my baby. They're my nieces. One of the things I wonder about with that difficulty of getting folks in is just some of the cultural beliefs about grief, and that's something that's very private, it's quiet, it's sort of hidden, and
I'm afraid to come to the beginning, they'll start crying.
yeah.
I think that would be a problem in South Texas more so than any other parts of the country where there's such a large Hispanic population. And maybe I'm wrong, but
Yeah.
there's sort of a, I don't know if macho still exists in this part of the country, but when I lived down here, it did.
Yeah.
And that's been something that's come up in the group before, just those gender differences around grief, and that second section where we talk about those different cultural, societal beliefs and influences on how do we go about the process of grieving and mourning. It has definitely come up in that experience, and wanted to make sure that was at the beginning of this session, so that was just immediately on the table. What are those ideas that you've learned from your family, from your religious tradition? Just kind of make that, become more aware of that. And I'm aware of our time here too, and wanted to allow you folks an opportunity again to kind of experience a little bit of what we've done. And thought it might be, again, knowing sort of what you've covered this morning, thought it might be valuable to go through that second session with you. And if you all are open to that, to whatever degree you feel comfortable sharing within this setting, I'm going to go ahead and on page 19